Hello and welcome to Bridging the Gap, the interview series that talks about innovations impacting behavioral health. I'm Chris Molaro, CEO and co-founder of NeuroFlow, and today's host. Thank you for joining me. Today we're speaking with Dr. Brian Daly. He's the department head and associate professor at Drexel University's Department of Psychology. He's also a private clinician. He's specialized in child and adolescent psychology. Interestingly enough, I got to know Brian for 6 years. He started out as a customer of NeuroFlow's, and then we got to know each other a little bit more. He started advising the company. I've learned a lot from him over the years. And I'm excited about today's conversation because he has a lot to share in terms of his own research, what he's learned, what he's seeing today in the world from a mental health perspective. So I'm excited to learn a little bit more myself today and share with all of you what Dr. Brian Daly has to offer. Thanks for joining me today, Brian.
You're welcome. Thanks for having me, Chris.
Of course. For our listeners, can you tell us a little bit about your background? And you wear 5 different hats, basically. So what are those?
Yeah, so I am currently the department head of psychological and brain sciences at Drexel University. So that's my main job. I'm also a clinical child psychologist, so I do some therapy work and some assessment in terms of a private practice. And then I'm an advisory board member for NeuroFlow as well.
Yeah, which is awesome. And actually, for our listeners, you started out as a customer.
Correct. And remain a customer.
Yeah, that's right. And you were like, I love what you guys are doing, and I want to be involved more, and can use my help in terms of advisement and stuff like that. And I mean, we were way earlier. This was 5 or 6 years ago. So we were lucky to find you. Thanks for everything you do.
You're welcome. But I was very attracted to the mission of NeuroFlow and remain, quite bullish on the intersection between technology and mental health. So even way back then, even though it was sort of early going for NeuroFlow, I was aware that technology was something that was going to be important to support the behavioral health needs, the mental health needs. For me, that was around child and adolescence. But I remain, again, I think very committed to that concept being something that provides additional layers of support to what we didn't know back then, because it was prior to the pandemic, has become an even bigger issue, although it was already quite urgent back then too. So the mission was something that has stayed the same at NeuroFlow, even if the company has evolved a bit. And I'm still so pleased and honored to be a part of it.
Thanks, Brian. Appreciate that. And aside from NeuroFlow, I'm really interested to learn more about, so when you say child psychologist, that could be anything from like 0 to, what, is it up to 21 that you do? Or
Correct.
Okay. So I'm sure that teenage years are a lot different than 8 or 9 or 10 years old. Is that fair?
That's a fair statement, yes.
How do you do psychology in that broad of a range of people? And I guess, how do the challenges differ between the sets of people?
Yeah, it's a good question. In many ways, the challenges are broadly similar, and yet I'd say they're discretely different at the same time. Mm-hmm. So the broad one, when we think about clinical child and adolescent psychology, you're still going to hit on the big domains. What's happening in their social life, what's happening in their academic life, what's happening in, for lack of a better phrase, sort of their emotional life, right? So those remain the big ones, and family is a big part of that domain too. So if you think about the broad domains, we're always evaluating those, whether it's a 5-year-old that I'm seeing or a 14-year-old that I'm seeing. But I will say what's happening academically, socially, within the family, or even emotionally with the 5-year-old is going to look quite different than what's happening with a 14 or 15-year-old too. So right. Some of the training that I've received over the years is around development and how development looks quite different in those stages, even if you have that broad overlap. So if I'm seeing a 5-year-old, for example, I'm still going to look at those domains, but I'm going to think differently about how those domains are impacting the 5-year-old than when I get in the room with a 15-year-old, in which the social life is looking a little bit different at that point, right? So I think, by 15, often there's a lot more social challenges. They're navigating a lot more nuance within their social life, whereas a 5-year-old, and again, you're thinking kind of pre-kindergarten at that point, where most kids are really getting along with all of each other, and it's great. And then you get to 2nd or 3rd grade, and you start to see differences socially, where kids are moving more into cliques. There's differences boys are hanging more with the boys, girls are hanging more with the girls. And then you move along up to 15, and I think you just have a lot more social challenges that are coming. Kids are trying to find ways to fit in, and I think anybody who's been through the teenage years knows that's not a very smooth process.
No, it was the worst process.
Yes, yes.
It was.
Yeah.
I mean, so when you're dealing with children, I guess the evolution from child to adolescent, I feel like that has to be such a critical time, obviously. How do parents come to the equation into this? I mean, I imagine like the stability or lack thereof at home could have such an impact on that development era. Is that a fair assessment?
That's a fair assessment. I mean, parents are always involved, but again, this is where broadly they're always involved, but there's, I think, some unique differentiators too. So just for example, if I'm seeing a 6 or 7-year-old in therapy, most often I'll have the parents in the room for a lot of that session because I think they're serving more as the agents of change, even if you think of the child as the identified client, and I tend not to because it's really a family systems issue at that point.
Yeah.
I'm working a lot with the parents to help be coaches, facilitators, leaders as parents in terms of working with the kids and whatever the presenting problem may be, and that could be anxiety or depression or ADHD or behavioral issues, academic issues, social issues. So I'm trying to deliver an intervention in which the parents are really key players in that. Then when you move up to the adolescent years...
What if the parents are part of the problem, though?
If they're part of the problem, and that's a great question, then I'm working more directly with them. And I think, again, within a family systems unit, everyone is part of the solution, too. So we think about it not more as who's really the problem here, but who's going to be part of the solution. How do I get them on board to being part of the solution, too? And I know that's just looking at the other side of the coin in some ways.
Yeah.
But we do know that if you want a child to get better, particularly let's just say at 6 or 7, if I just work with the child, they'll get a little bit better, but probably not to the point where we want them to. I need the parents on board. And I found usually in my work with them, they are on board. They're stuck at the time, which is why they're coming to see me. In many cases, they've tried a lot of different things. It just hasn't worked as well. And they're coming and saying, look, we want the best outcome for our child. We just don't know how to get there. And then that's my job to, I think, work with the family, work with the child, work with the parents, and chart out a path for them to implement some things in the home environment, sometimes in the school environment, sometimes when they're with their social peers, that's going to help them get to the point where the child is functioning a lot better. Then when you get up to the adolescent years, there is a shift, right? Because, again, who's the agent of change there? It is still the parents have to be part of that solution, but most often you're working a bit more directly with the adolescent, where you just have a different level of cognitive development, a different level of insight,
right.
Hopefully a different level of an adolescent's ability to be more independent in some of the changes or enacting that plan that I want them to enact. And so there is differences between, say, that 6 and 7-year-old and then the 14 or 15-year-old when I'm working with them. But nonetheless, even at 14, 15, I want the parents involved.
Right.
How much they're involved,
them.
right?
Yeah.
How much I'm coaching them, how much I'm sharing with them about what's going on,
right.
can be a little bit different than the 6 or 7-year-old. But I don't, I've never felt like in the adolescent world that it's just the adolescent that needs to change. It still remains a family systems issue.
Yeah, looking back on how you've been doing this for how long now?
Probably close to 20 years at this point.
Okay, so 22 decades.
Mm-hmm.
A lot has changed in 2 decades. And so, like, looking back on what has changed, I mean, you have 60 Minutes just recently did a show where they talked about how the CDC's findings where suicide attempts among adolescent women are up 50% since 2019. Suicide is the number 2 cause of death for adolescents and people in their 20s, which is different than when you first started. What's changed? High school is, I'm sure, maybe it's more tough today. I don't know. Is there a common data point that has changed in your purview, or is it? I guess just what's the attributable reason for that increase in suicide, depression, anxiety, that sort of thing?
Yeah, it's a great question, and I think it's a difficult answer to pinpoint because I actually think it's multifactorial. And I think sometimes we either as psychologists or the lay public sort of look for the one silver bullet to say, well, this is
this reason.
This is the reason, and if we
Yeah.
just fix this reason, everything's going to get better. And I think lately it's been social media, right, which is undoubtedly a contributor to some of this. And so then the focus, too much of the focus becomes, we'll address social media and all of this will just, suicide rate will drop, right? And
But what does that mean, address social media? Like not allow them to be on social media?
Right. Well, I don't think that's
Or
the
censor-
answer
yeah,
either.
exactly,
I think
yeah.
it's trying to find ways to use social media in a way that doesn't isolate kids more, that doesn't expose them to more bullying, that doesn't expose them to something that's going to really decrease their self-confidence or self-esteem or feel like they have to be somebody different. So I think it is trying to have conversations with adolescents about using social media in a way that, again, is going to be both enjoyable and protective. So it's not something that is causing a regression, for example, in their emotional state because of how it's being used.
You mean in terms of like, what they're exposed to, when they're exposed to it, or the risks that, I guess, that they're exposed to more bullying and stuff like that?
Exactly right. So I think it's the exposure to the bullying that can happen on there. And I want to be careful with the word bullying because sometimes it implies that there's this power differential, and I think there is, but it is this communication pattern on social media in which it can be, sort of unnamed sources that are doing it, or people within the school that can be hard to have a real conversation with afterwards to try to mend fences about what was said. So I think sometimes it's an echo chamber on there that I think is unhealthy for certain adolescents who may be at risk for that type of communication pattern that's going to make them more upset, impact some of their self-confidence or self-esteem too.
So we always want the one silver bullet for a solution. It doesn't seem like it's in this case. Is there solutions that you've deployed or strategies that you've deployed that are helpful in that? I mean, it sounds like coaching having a conversation with your kids, right? You have two sons. I'm a new dad. I have a daughter. Like as she grows up, wanting to have those conversations with, these are the risks of social media and stuff like that. But
yeah, I think
kids are mean. Right?
Kids are mean, and I think our job as parents is to help them navigate what is a complicated, complex world. And there's a word that you use that I think is so important here, which is conversations. It's ongoing conversations with our kids at all these different stages of development, because the conversation that you are going to have with them, for example, at 15, might look a little bit different than the conversation you're going to have with them at 7. Again, and some of that is around what are they doing differently at 15 that they weren't doing at 7 or vice versa. So the ongoing conversations are so important, and I think they can be difficult conversations to navigate with kids. And back to the point around coaching, some of my job, I think, as a therapist, is to do some of that coaching of parents to say, here's a different way to approach this conversation where you can start to get into the complexities, the complications that happen in this world. So I think this goes back to what we're talking about as multifactorial, right? So there's a fair amount of social, political upheaval happening in the world now. I think in a really positive way, the stigma of mental illness has been reduced post-COVID. On the other hand,
But people are talking about it more.
people are talking about it more. I think they're more comfortable sharing it. But what we've also seen is as the stigma has reduced, we don't have the resources to meet the need, right? So more people are talking about it, that's great. But even in psychology or counseling, we don't have the workforce to meet the needs at this point, right?
Yeah.
So just having spoken with parents who are looking for a referral for their son or for their daughter, I really struggle on where to send them, because when I send them to the people that I know, the wait list is 3 months or 6 months. And
or they don't accept the insurance that they want.
or they don't accept the insurance, or even with telehealth. I mean, you just have a lot of counselors that are fully booked at this point, and they just don't have the capacity. So as we came out of COVID and the stigma reduced and the need increased, we don't have the workforce to support them, which I think is probably one of the biggest issues that we're dealing with now. I do think the federal government promisingly has committed more resources to it, but even when you commit more resources, there's a delayed effect to that workforce being built up. And I think we're in a place right now, and maybe this is reflective again of some of the increase in suicidal thoughts or behaviors or completion, sadly, is that we don't have the workforce to support the needs.
Right. I want to get to the workforce discussion a little bit, especially in your role as the psychology professor. But before we do that, I guess Have you heard of Jonathan Haidt, author of Coddling American Mind and
I
so
have.
forth?
Mm-hmm.
It's pretty interesting. I just read that book, and on his podcast too, he talks about, we have age limits for driving, for drinking alcohol, for buying cigarettes, all these sorts of things, and has proposed, and I'm paraphrasing what he said, so Jonathan, if you're listening, don't hold me to this. We'd love to have you on the show. To have age limits for social media and for the internet and stuff like that. It sounds like that might be contrary to what you're saying, though, is that that's not part of the solution. Do you see any benefit to that sort of strategy?
I'm not sure. Sometimes that can be taking a hammer and hitting the nail approach to it.
Mm-hmm.
That I think if parents can have ongoing conversations, right, with their kids. Again, that's not a perfect answer to it, but I think it is something better than what's happening now. Is we have a one-off or two-off conversations with our kids about social media. Then things are happening on social media we're totally not aware of. We're not checking in with our kids. We're not monitoring it as well as we should. And then, before we know it, we're having to deal with a much bigger problem.
Right.
And once it becomes a bigger problem, it's always a little bit harder to deal with. I mean,
Mm-hmm.
one of the reasons I got into clinical child psychology is because of prevention. That's what I think I like to gear my intervention strategies around, is how do you prevent something from becoming a bigger problem because you address it earlier?
Yeah.
And prevention, in this case with social media, is having those conversations early, having them often, revisiting them, understanding that there's going to be new complexities to some of the conversation as they get older. And I think it can be a challenge as parents, particularly as kids get older. They're actually more reluctant to have these types of conversations, but that's probably the ideal time to continue to engage in these conversations. So I think the age restrictions is maybe taking a solution or applying a solution that I think is not going to work for as many people as we would like to think it would work for. Right. So in the absence of that, having these ongoing conversations is another strategy that I think we're in society learning how to deal with, because the technology is advancing faster than we can keep up with in many ways, which again just suggests that we should be having more of these conversations.
So it sounds like, maybe beating a dead horse here, but you're coaching the parents and having the parents be involved with is key and critical. Now, but there's a balancing act between, so I'm a parent, you're coaching me. How do you strike that balance between being overbearing with your kid, and being involved, and that balance of being productive, not, obviously counterproductive? Is there a rule of thumb that, from a psychology perspective, you go by?
It's a good question. Back to the hammer analogy, just for a second, of the hammer metaphor is I don't want you using the hammer, but I don't want you using the small needle to fix something too. I think it's having, again, back to like a toolbox of different things, right? Mm-hmm. So there are times where, you're going to want to have a more serious conversation around social media, and times where you're going to want to have a less serious conversation about social media. Maybe in some ways that less serious one is just understand what's happening there a little bit too. And the more serious one is when you're willing to put some restrictions, some guardrails, some guidelines around it too, which I think is really important, that parents who stay involved and they take what seems to be a consistent approach, but also approach that has some level of warmth to it and understanding around it, is usually the right strategy. Mm-hmm. That if you come in too hard, I think that's problematic for the kids. They'll sort of push back against that. And oftentimes you don't know what they're doing because you've come in too hard. And if you come in too soft, to be a passive parent is not the right approach either.
In other words, if you come in too hard and just say no across the board, they're going to find a way to do it anyway, and then you're not going to have any insight into it.
Yes, and I think that's a concern if they're doing it and you have no understanding of what's happening. Right. And again, if that becomes a problem and you didn't know about it, by the time that you're addressing it, it's advanced further than you would have liked it to advance.
Parents are one part of the equation. The majority of their day, at least when they're awake, is spent not with their parents, but at school. How are schools a part of the equation as well? And, I guess, how do the parents and schools can work together in a more productive way?
Yeah, that's a great question. I mean, a lot of my research work is school mental health, so I work a lot in schools. And
let's talk about it. Yeah.
We'll talk about it. I'm a big fan of schools. I think they play a big role in this. You're correct. And I think actually conversations between the leadership at schools and parents is really important. Mm-hmm. It's not to say that's not again, sometimes a complicated, difficult conversation to have, because I think schools have an opinion and parents have an opinion. It doesn't mean those opinions are always align. But schools that come up with more clear and consistent policies around, for example, the use of smartphones in school or social media is really important, so parents understand what is being allowed in the school, what's not being allowed, but also what's the rationale behind it. How did they develop some of these policies, practices, principles, guidelines around it too, so that the parents can feel like they at least understand it, even if they're not exactly on the same page, but they know where it's coming from. And I think, again, some of this technology is advancing so quickly that schools are falling a little bit behind too. And I think we want to make sure that everyone is at least having that constructive conversation back and forth.
Is there a, I guess it probably varies widely from school to school, but in terms of this leads into now the shortage of mental health professionals. There's not enough mental health professionals to embed everyone in every single school, or is there? I don't know.
There's not, although there certainly isn't. In the workforce shortage, we see it in schools, undoubtedly. And I think coming out of the pandemic, again, the federal government, to their credit, and state governments recognized that putting more providers in schools was one of the strategies that they should be implementing, because kids spend so much time in school, because so many of their challenges are happening in the school system, that's where we need the providers. And I think there was a recognition that the providers on the outside, so psychologists like me in private practice or others in community mental health centers, there was a big shortage there too. So they have provided a lot of funding to get providers into school mental health. We, interestingly, with the funding there, there's a workforce shortage. We're not hiring them as soon as we need to be. We don't have them trained as well as we should be training them in best practices at this point. So I think there's a recognition, but with the recognition, the reality is not meeting it yet. So hopefully in a couple years, we'll see more progress there, but we're definitely behind the curve.
In terms of places to embed psychologists, now, interesting, your private practice is, as far as I understand, is partnered with a pediatric clinic, right?
Correct.
And so that's like the physical health side of things. Now, obviously, at NeuroFlow, we believe in the connection of physical mental health. It's just one and the same. Like, how many times when you have a bad stomach ache or you're feeling ill, it's highly, highly correlated, if not causated, by anxiety happening in your life and so forth. What is that connection that you see with the pediatric clinics, and how do you, as a mental health professional, effectively collaborate with the physical health colleagues on the other side of the table?
Yeah, it's another great question. I'd say it starts with relationship building, right? So I think there is definitely a recognition by pediatricians that physical health and mental health highly interact. And there is most definitely a recognition by psychologists that physical health and mental health interact. And yet we're trained to sort of specialize in one or the other and not always do as well as we can in terms of the holistic care of the child or adolescent in this case. So you do need to build the relationships with the pediatricians to say, when you refer somebody to me, here's the type of information that's going to be really helpful to me so that I can provide the best level of care. When you're a psychologist and it's a mental health issue, but you see that there may be some behavioral health or physical health issues going along with it, that you are providing similar information to the pediatrician. And I think that the fracturing or fragmentation in the mental health and behavioral health system is because there's not relationships that are built. And so there's these one-directional referrals that happen. There's not the right information that gets shared. There's not collaboration that occurs. There's not holistic treatment. And so then you have families going to 7 or 8 different places to try to find care, which again is just not ideal.
You mean for the mental health care?
For the mental health care.
So it's the pediatrician just saying, here's a list of doctors, call them and see what's available?
Right, which turns out to be a black box because probably 6 of those 7 that you call are not taking anybody for 5 or 6 months, and there's no relationship that's established. And in this world, a lot of that, the vouch is really important, where a pediatrician says, I work with this psychologist or this group or this community mental health center. They're very good. They're going to provide good care. That makes a world of difference to the family who's hearing that versus, here's this piece of paper with 7 names. Good luck. See you later.
And again, most of those people might not be available.
Correct.
In terms of your research, has that been a focus for mental health in schools? have you focused on a certain type of school, secondary, elementary, university? Is there
We're in the elementary schools in the Philadelphia public school system.
your research, man?
Correct.
Yeah.
Yeah, and we deliver a social emotional learning program, which is providing foundational skill development around things like, for example, it has to do with how do you make friends, how do you learn how to share, how do you do your best academically, how do you manage your emotions, including anger and frustration tolerance. So we're trying to, again, this goes back to prevention, provide them with these foundational skills so as they advance from first grade to second to third to fourth, that some of these skills are better developed, which again is hopefully preventing some of the future problems that occur.
And I guess, what have you found in your research? Or is it too early to tell?
So we've found actually in classrooms, for example, of 25 kids, 21 are doing great. They probably don't need, we do a universal intervention approach, which means the whole classroom gets it. Don't need as much, although they can benefit a little bit, but there's 5 or so kids in there that actually really benefit from it, and that's quite important. And the way that we deliver the program is with psychology graduate students, but we also include the teacher as one of the group leaders, but we use a sort of a peer approach too. So it is the peers who have well-developed pro-social skills, who have well-developed skills around managing emotions, that I think are actually the best models for the other kids who are struggling a bit.